Welcome to the Power of Partnership and Collaborative Approaches in Plastic and Breast Surgery. Did you know that collaboration between your plastic surgeon and your breast surgeon can significantly improve your breast reconstruction outcome? Well, if you didn't, we're here to tell you all about it. I am joined by NIBRA plastic surgeon Dr. Jonathan Bank, New York Breast Health breast surgeon Dr. Craig Larson, and Katherine Lewandowski, who used both of these surgeons to have a risk-reducing procedure. We'll hear from provider and patient perspectives to talk about how to craft a collaborative approach and how this benefits the patient. To run through our esteemed guest, Dr. Jonathan Bank is a microsurgeon, surgical trained plastic surgeon practicing in New York, specializing in advanced breast reconstruction techniques, resensation, and post-mastectomy pain syndrome. He is known for combining art and surgery in projects like Reconstructed and Reblossom, innovating the Reviver device, and founding Breast Relief. Along with that, he contributes to academic research and medical boards, including breastreconstruction.org's own board of directors, the Heirs Foundation, and Larger Than Life. Dr. Larson earned his medical degree at the University of California, San Francisco, completed a general surgery residency at New York Presbyterian in Queens, and a fellowship in breast surgical oncology at Allegheny General Hospital in Pittsburgh. His commitment to breast cancer care was influenced by close family experiences. Dr. Larson has worked with diverse populations in Guatemala and Zimbabwe, is fluent in English, and is excited to be a part of New York Cancer and Blood Specialists. He specializes in nerve preservation, resensation during breast surgery, various localizing techniques, oncoplastic procedures, and both electrocautery and tumescent. He's passionate about languages and has traveled to over 20 countries. And finally, we have our patient, Katherine Lewandowski, who underwent risk-reducing mastectomies with deep flat breast reconstruction in October of 2023, 6 months after learning she had a BRCA mutation at 43 years old. 3 months later, she underwent bilateral laryngoplasty with a GYN surgeon at the same time that her plastic surgeon did minor revisions to her breast reconstruction. Collaboration between her 3 surgeons allowed her to reduce the number of surgeries as well as minimize spending. Katherine is a senior program officer at the Wallace Foundation, where she works toward improving equitable access to high-quality youth development opportunities for young people across the country. She lives in Brooklyn with her husband, 2 children, and dog, Kula. And in her free time, she enjoys urban gardening in Prospect Park. I'm Katherine Lewandowski, the Director of Content for breastreconstruction.org, your go-to resource for all things breast reconstruction. Katherine, I would love if you could get us started by talking about why you chose to have risk-reducing surgery and how you chose your doctor.
Sure. Thank you so much. When I was doing my research, interviews like this were so helpful to me, and I'm hopeful that this might be helpful to someone else down the line. Before I talk about my decisions, I think I would be remiss if I didn't, first of all, acknowledge the enormous privilege I had going into this process. I was in excellent physical health. I have really good health insurance, paid time off work, supportive partner. I live in a major city, and I have the education to read medical research. All of these things undoubtedly inform the choices that I felt like I had available to me. So as Karina mentioned, I was 43 when I found out I had BRCA. It was just after my father was diagnosed with metastatic prostate cancer. My dad was an only child, and his mom died really young. So I actually had no family history of breast cancer. It really came as a complete surprise to me and my family. However, I knew pretty much immediately that I wanted to have a mastectomy. And that was for 2 reasons. First and foremost was access to hormones. As a BRCA2 carrier, based on current data, there's no longevity benefit to a mastectomy over intensive monitoring. However, were I to be diagnosed with breast cancer, I would not have access to hormones. And given that I also needed to have my ovaries removed and be put into surgical menopause, frankly, the idea of unmedicated surgical menopause was much scarier to me than any kind of surgery. a couple months ago, there was a FORCE research panel, and one of the doctors was cautioning medical providers against too strongly recommending prophylactic mastectomies for BRCA carriers, given the risk not only of surgical complications, but also of negative impacts to body image and sexual health. I'm sure this was easier for me than it might have been. I'm married, I breastfed my children. My breasts have always been small and not a major part of my sexual identity. That said, hormones are vastly more important to my sexual as well as overall health than having natural breast tissue, and that would be true even if the cosmetic outcomes that are possible are not so excellent. Honestly, I feel like it's pretty revealing of our society that my insurance is mandated by federal law to do endless breast revisions, and yet we still don't have an FDA-approved testosterone for women when we know that testosterone is essential for women's sexual health and desire, and that our ovaries make half of our bodies. So that's hormones. Secondarily, I think it's more about my disposition. The surgery was a scary thing to do, and it was challenging, but it was also really exciting. I mean, I think that we do all these things in our lives as we get older to try to make our lives safe and predictable, and this felt like something where I really got to step outside of myself and see what I was capable of in a way that I found really invigorating. And I got to meet people. It was overall a really positive experience, and I can't imagine trading that for monitoring to see if and when I would get breast cancer. Do you want me to keep going about how I found Dr. Bank?
Yeah, just keep going. You're doing great.
So once I decided that I was going to have a mastectomy, my primary concern was having any sort of lingering pain. Exercise and being active is really important to my mental equilibrium. So my primary concern was that I would have any sort of morbidity or pain that would keep me from being as active as I need to be. So I assumed correctly that if I could find a surgeon who was interested in treating post-mastectomy pain, he would probably be conscious about trying to prevent it in the first place, which was true. Secondarily, I only really wanted to do a reconstruction if I was confident I could get a really natural looking result. I wanted to do deep flat, had pretty limited abdominal fat, even less now. So I needed someone with the technical and aesthetic skill to give me that. So I read the internet, literally, and I found Dr. Bank. And then I did some very intense Google stalking of Dr. Bank. I read everything I could find that he'd written. I listened to interviews like this. I talked to former patients of his online, looked at all the pictures he put on Instagram, and I ultimately decided he met the very high bar of someone who was worth traveling to Long Island to see. And I figured if I trusted him enough to deconstruct and rearrange my body, I also trusted him enough to recommend my other surgeons, which is how I came to have Dr. Larson and Dr. Katz, my GYN surgeon.
Okay, so it sounds like, if you can hear me, it sounds like you chose Dr. Bank first, which is a little bit unusual. Dr. Bank and Larson, if you want to just jump in and talk about how the order of operations worked here, how it typically worked, and really how you all collaborated in Katherine.
Sure. I just wanted to clarify, Catherine, the pictures you're referring to, those are my fruit salads from way back on Instagram. Did you scroll that far back? Because those are near and dear to my heart. Uh, s- Second, I want to start with, you mentioned how you met people throughout your journey, and that's been helpful, I think, to you. And I think that's, cliches aside, it's probably the most rewarding part, if not the most important part, if that's even different, of what we do. It's we can think about taking care of breast reconstruction, doing all these technical steps, but we must keep it in the context of human beings and the person that's in front of us. or else we're doing half a job. Um, and I think in Dr. Larson and several other breast surgeons that I work with, we find that we work together because we share that same mindset. And as I sort of progressed in my career, it went from just doing this technical exercise of how to reconstruct a breast that looks good, also feels good, but has to feel good in the context of that human's life. So that's how I became interested in taking care of post-mastectomy pain issues, because in the beginning at some point I started being able to reconstruct breasts that look good, but people would have complaints that they just didn't feel good. They had areas that were painful and tender, and then I realized that that has to do with the nerves that we sometimes have to sacrifice as part of the mastectomy because they traverse through the breast tissue. Our goal is to do a safe procedure from an oncological standpoint, take care of the cancer or minimize the chances of it even emerging. And so some of those nerves have to be cut, others can be preserved, and that's where the collaboration with the breast surgeon that again thinks in what I just like to call modern terms of mastectomy. And modern is today's age where we have a better understanding of the anatomy of all the structures that comprise the breast, the skin, the fat underneath the skin, that harbors the majority of the blood vessels and the nerves that supply the breast skin and nipple areola complex that provide sensation, protective sensation, erogenous sensation. And then the breast tissue sort of lies beneath that. And there are nuances that you have to be astute enough as a breast surgeon to identify them. And in olden days, where mastectomies were done typically in cancer patients that presented fairly late because we didn't have good modalities for imaging and diagnosing at an early stage, definitely knew nothing about any of the genes that are associated with breast cancer. So we didn't have the privilege of doing preventive mastectomy. It was always kind of behind the eight ball mastectomies, and sometimes very late. So our forefathers in breast surgery and in plastic surgery had to do what we call radical mastectomies and things that are much more extensive. And because of better understanding of the anatomy, earlier diagnosis, genetic information that we have, we've been able to get to that stage where we can say, okay, not only do I just want to, I want to prevent or reduce the risk as much as I can surgically to get breast cancer, but I also want to mountain climb and do all these other things that are really important to me in my life. And I'm glad that I'm practicing in an era that our forefathers, climbed their own mountains to get to the stage that I could provide these opportunities for our patients, and I'm sure it's going to get even better at some point. So, yeah, finding a good partnership with a patient that tells me these are my demands, this is what I need to get to, find a way, figure out how to do it, put up a good team that can get us to that. And fortunately with Dr. Larson, and again others, there's a great collaboration. I think that helps us push the field.
Okay, well, thank you. I have now put in a pair of wired headphones. Maybe this will help with the shenanigans on my end of this, for which I sincerely apologize again. Anyway, we've heard from Katherine, we've heard from Dr. Bank. We'd love to hear a little bit from you, Dr. Larson, about collaborating with a plastic surgeon and how that works, and how you approach Katherine's case, how you approach all this stuff.
Yeah. So what Dr. Bank was saying, I agree with completely. We work very closely together, and we both care about the same things. So oncologic safety, when it's a cancer, making sure that we get all the cancer safely, and with these risk reducing the BRCA patients or their similar mutations, that we're able to get to them before they get a cancer, still doing the safest procedure possible, but also being mindful of these other things, being mindful of the nerve, because you can do two things. You don't have to, compromise on the oncologic safety to save the nerves, and so that's something that we both really. another thing that that Katherine was mentioning that I think is really important is kind of the privilege that she had, being able to have time. She wasn't rushed to get to the operating room because of a cancer, and also the privilege that Dr. Bank, explained. We have the privilege of finding cancer earlier and earlier, so we're able to do better and better surgery. We're also living in an era where breast fellowship is a thing, where instead of just doing general surgery and then doing a breast case here or there, part of your general surgery career, we have a lot of thousands of surgeons across the country who specialize in this and are passionate about this and do this and think about this all day, every day. So I think that's another privilege. And then kind of going beyond that, having access to things like Instagram Live, having the internet there before you, where you can look up, people who care about things that you do as a patient. And Dr. Bank and I have had patients from, several places across the country who didn't have access to what they needed, what they wanted, what they deserved. And so we were able to take care of them. And, having, being able to do that as a patient would be much more difficult than 10 years ago. But that's an important, and I think the last thing, as far as privilege goes, it's important for me and Dr. Bank to kind of try to extend that to as many people as possible. So, for example, I have a house in Long Island and one in the Bronx, and we get a mix of patients. I get a mix of patients in both places, but a lot of my patients in the Bronx come. They don't speak English. They don't know to advocate for themselves. We don't have as much access in Spanish to some of these same themes, but trying to offer that same level of care, and caring about the things that they haven't thought about.
Exactly.
That they care. And so I think that's really important to understand where we are and try to get that to as many people as possible.
Yeah, and that's, oh, no. The headphones made it better and then worse. And now I just have a scratching noise. Dr. Banks, do you want to just talk about how to find breast surgeons and plastic surgeons who can work together efficiently?
Yes. So, as much as Craig and I like to think that we're special and unique, we're actually very much not. They're pretty much across the country. Breast surgeons and plastic surgeons work hand in hand, and frequently they'll be teamed up either as part of an institutional policy or just how practices have developed in various pockets of the country. So it's not unique to have this team, and I think it's people understand that people that know each other, that work together for a long time, they just develop a certain language, and it helps outcomes across the board. And I think that approach is like across industries. It's nothing special here. Another thing that is trying to make us less special is that we actually teach other plastic surgeon, breast surgeon duos to do these kinds of operations. So both Dr. Larson and I teach courses across the country with the Accident Company. And Accident is a company that makes the nerves and the other materials that go into nerve reconstruction. Those are the resensation techniques. And they understood their mission is not just to be a successful company, but they really want to elevate the level of outcomes for patients. And so they're not just trying to sell us the material, they're trying to educate us as professionals on how to do these operations. So when I took one of the earlier courses several years ago, it was just dedicated to plastic surgeons. And it was pretty much a technical thing. How to connect the nerves, how to handle them correctly, what goes behind manufacturing and processing the nerves, and the other products that are used for it. But very quickly we understood that the plastic surgeon or the reconstructive surgeon is just half of the picture. We really need to get the breast surgeons on board, because the best outcomes come from, again, a team that works together, and specifically in this context, preserving the nerves that are able to be preserved, and setting up the plastic surgeon for success for nerves that have to be harvested. So back to that anatomical description, when a mastectomy is performed, and mastectomy can be done through various incisions that I'll talk about in a second, because that goes into part of the planning and part of the discussion between the two doctors and the patient. Once the mastectomy is done, meaning an incision is done, the breast surgeon basically separates the nerves with the tissue underneath the breast skin and then removes the actual breast tissue. On occasion, nipples may have to be removed if they need to be because of oncological reasons or due to anatomical reasons. And so as many nerves as possible will be preserved. Nerves that have to be sacrificed, it's important for me to have a healthy nerve to work with. So if there's an approach that basically disregards the subtle anatomy of the nerves and how to handle it, we won't have a good platform to do a viable reconstruction of that nerve. So a lot of that course goes into just a reminder of the anatomy, the various approaches to preserve the nerves, and the various approaches to reconstruct them. And it's taught together. We're not separated, plastic surgeons and breast surgeons, so everybody's on the same page.
Collaborate too, because we're in the surgeries at the same time. So if I'm pointing out a nerve, I'll identify it, get as much length as I can for him, show him, kind of tuck it where it's protected, and then it's just the simple things like that working together, having a relationship, knowing what he's looking for, knowing what I need, and then getting the best outcomes for the patient.
Great. So I'm going to jump in with, rather than wait for Karina, because your sound is so bad. So the power of partnership is the title of this, which I know is mostly about you guys partnering. But I wanted to talk about what Dr. Bank mentioned, which is really the way he cares for his patients. This was a big surgery. I was super lucky. I healed from it quickly. I didn't have any complications. The pain is not, people are afraid of pain. Pain, it hurts for a couple of days. It's not the thing. What is really hard is there's just these weeks and weeks on end where you feel pretty useless and weak and exhausted. And you don't really know on a very fundamental level if you're ever going to feel normal and strong again. As Karina mentioned in the intro, I work in youth development. And in youth development, we have very strong data around the power of caring adults to mitigate trauma in kids' lives. If a kid feels seen and believed in by a trusted adult, it can lead to pretty radically improved outcomes over what we would otherwise expect to see. So I know this, I know the power of relationships, and it's still totally surprising to me. And I think that was, like many people who don't know any better, I was kind of dismissive of the idea of bedside manner. You think of doctors nowadays, I don't think it used to be like this, but surgeons in particular really as technicians that are doing something, not as people who can actually partner with you and support you while you're healing. When I met Dr. Larson and Dr. Bank, you guys probably don't remember this, but for the first time I asked you about each other, and you both described each other as real people, which is an unusual compliment for surgeons to give one another. Before I even had my first consultation with Dr. Bank, I had asked a question through his portal, and he texted me back an answer. I think he was in Italy. I think you were working on your book or something. He called me the night before my first surgery to see how I was feeling. He held my hand on the operating table before my second. And what this demonstration of caring and authenticity and availability meant is that when I would see him at my post-op check-ins and he would tell me he was proud of me and that I was doing a good job, it actually mattered because I wanted him to be proud of me. And when he told me that I was going to be okay and that I could really listen to and trust my body, I believed him. And that's a pretty powerful experience to have if you're a kid, a grown-up, really, just like as a human. Um, because I was 43 when I found out, there was really no reason for me to wait on anything. So from the time of my diagnosis with BRCA until I was fully recovered and healed was 10 months. And as soon as I realized that my body was strong and the hormones were going to let me keep feeling like myself, I just had this like veil of anxiety. I didn't even know I was living under lifted, and this rush of ability to be really like present in my life and gratitude for my body. And I felt like Dr. Bank was really my partner through that whole journey, which was pretty cool.
I'm gonna unmute myself to see if this is horrible. We'd now like to just open things up to Q&A from anybody who has any questions who's joined us. We have some prepared questions, which we all have, and I might ask you to disseminate, Catherine, so that we can avoid the sounds that are happening from the side of things. Thank you so much. But in the meantime, if folks, if you have any questions about this topic, if you want to just jump in and throw them in the chat, feel free. And if not, seems like for the moment this is working okay. So I'm wondering from Catherine, just what level of sensation you have now? Because I know resensation was part of this, and that's a common question.
So if I grab my breasts, they feel completely normal. Like there's no obvious places where there's numbness. I think I have the tops of my breasts. There's areas where I need, it's like deep pressure sensation. And then there's areas where I have full sensation on like the sides that I had from the beginning. I have had like no breast pain. I've really recently had like very, very mild like nerve zingers, but I literally had no pain whatsoever when I was recovering, which was my goal. And I also did my first real push-up when I was 7 weeks post-op, which was a goal.
I'm gonna just butt in here because I have to go take care of something quickly. But I want to say two things. Number one, I think that the minimal pain that you experienced is because of how we manage the nerves, because I think a lot of post-mastectomy pain has to do with nerves that are cut during surgery that may be managed differently. So I think that's a huge component. I think a lot of the sensation that you have is retained sensation from the mastectomy, and I think sensation that will, yes, it was a nipple-sparing mastectomy. I think a lot of that sensation will continue to improve. Some of it related to procedures that we did during surgery, some of it just natural regrowth of your own, the nerves that were retained. And recently, there are a couple of physicians from across the country, mainly the group at Cleveland Clinic, that really put science to practice, and nerves can regrow, and if they are given direction, they will regrow better and faster. And we see this in other applications such as hand reconstruction. They were doing it related to face transplant. At the recent conference we were at, the recent course that I was talking about, he presented amazing data that reconstructing the nerves is just one component. The nerves are then wired eventually into the brain, and the brain has plasticity, and we can retrain it and incorporate that into what we call sensation and feeling. And then the ultimate goal for some people, the erogenous sensation is critical, but you sort of have to retrain that. So they're doing amazing studies related to that, including functional MRIs that you touch one place and see where the brain lights up. But to bring it to kind of every day, if you go to resensation.com and scroll a little bit, you'll find essentially a rehabilitation protocol that you could do on your own at home. It involves various types of touch and various techniques of doing that, and that should be part of your rehab. I think that does, number one, it helps what we do. I think it continues, again, this is all about partnership, so it helps you be your own partner in recovery. So, you went and sought whatever doctors you wanted to find, but the job doesn't end there. You're still in recovery. You said that your recovery took 10 months. I always tell patients it takes a year to forget you had surgery. In that process, you could definitely do things and beyond. So,
My recovery did not take 10 months. It took 4 months, Dr. Ray. I want to clarify. It was from diagnosis to finding you to being all the way done.
okay, so I apologize for mishearing you. But I think for most people, well, you were definitely on the fast track, and one of the reasons that was the case is because not, well, I would say these surgeries are part physical, part mental. You went into this with the right attitude, and to me, that's all the difference. There's a patient from Seattle. I don't know if she's on today, but I started an event not long ago, and I said, I think about you every time, or I talk about you every time I consult with a new patient that may be having a DIEP flap, and I say, some people feel like they're going to be in a walker for 6 months, and they are, and some people are going to be up and walking in a week or two after. And I always talk about her and say that she showed me her cell phone, that she had walked, this is on post-op day 10, that she walked 10.4 miles the previous day, which I think is a lot. And then she scolded me and said it was actually 10.6 miles. So if she has that attitude, you're going to recover in no time. Again, barring any unforeseen events, which can happen, and you go to people that can take care of those unforeseen issues. But if you have the attitude that you're going to be stuck and it's going to take forever, that's what's going to happen. So you have to be an active participant on all levels. On that note, I'm going to take a break for a few minutes, and I'll rejoin you in a bit.
Thank you, Dr. Bank. Okay, I'm going to try to move on quickly again because of the feedback. This is a question for Dr. Larson about how you learned about nerves and whether all breast surgeons know how to handle nerves in the way that you do.
So I was lucky that I actually did my fellowship at a time and in a place where my program director knew about it, so she was able to teach me from the breast surgeon perspective. And actually, one of the plastic surgeons who worked at Cleveland Clinic that Dr. Bank was talking about had come to our site too in Pittsburgh. And so I had like a master class in it. And so for me, from the day of, the first day of fellowship until now, it's always been just a part of what you do, what is possible. It's not this strange new thing, because surgeons can be very much a stubborn breed, and once they've decided this is how I do it, that's how it is, and they kind of you get into your groove. And so for me, I was lucky that this high level of care and expertise was always part of just the norm for me, which I think makes it a lot easier to incorporate into your skill set if you learn it from the beginning. You don't have to unlearn kind of the negative, not necessarily the negative, but you don't have to unlearn anything if you learn it the first time. And I think that was very important to me, and to see it done very well and not have to feel like I was figuring it out and trying it out on patients with kind of variable initial results until I got up to speed. So that was another thing where I got to do it and see it enough during my training, when I had the training wheels on, that by the end I was able to do it by myself, without fear, without it being a big deal. And that's what you want. You want, this surgery is a huge deal for the patients. You're turning your patients' lives upside down. For me, I take it seriously. It requires a lot of concentration, but it's something that I do usually multiple times a week. And so it's not, the event for me that it is for the patients, and I get that. And that's kind of what you want. You want this to be, something that you're comfortable with, that, 99.9% of the time goes smoothly exactly as you envision it. And any, things that come up, you've seen 1,000 times, and you can kind of get through easily. And then kind of echoing what other people have said, it's important to take time, for me at least, when meeting a patient, to go through some things and make sure that they kind of know what to expect. Because if you expect to be bedridden for 2 months, that's going to influence your decision. And I think people need to go in with realistic expectations, because then you can plan for that. Because this takes planning on your end, because you'll need some help afterwards. And the other thing is, if I have a patient who's having a hard time making a decision, the last thing I'm ever going to do is tell a woman what to do with her body. So if I feel like somebody needs a little help and, isn't as decided as Katherine was, I'll offer her to speak with another patient, because I've done this, mastectomies thousands of times. From my side, I've never received one, and I know that that's a very different experience. And so I can talk about the pain and the drain and the this, and but I think hearing this, even if it's the same things from a patient, is important. And if this is something you're considering and you still feel like you have those kind of questions after you've seen your surgery team, it's not going to hurt to ask to speak to one of their patients who've gone through a similar procedure as well.
Absolutely. I said this before when we were gathering, but I really cannot overstate how important the community of women that I have met. I have now met in person 3 of my BRCA friends I've met online. One of them lives in Portland, Oregon. Another one, lives in Pennsylvania. And these are all women who are my age, who have become incredibly close with. I've had people call me after my dad died that I only knew online, texted me after my surgeries. I mean, it's been an incredibly powerful community of people who have shared their experiences of what they've gone through. And it's really, I can't imagine having gone into this surgery without having had those connections with past patients.
Yeah, I do. A lot of the work that we do with breastreconstruction.org does center around, getting patients to share their experiences just broadly. And it's for that reason. It's so that, folks can learn straight from people who have had the experience. Dr. Larson, a quick follow-up on the nerve-sparing end. Does it take longer to do a mastectomy that way? Or is the resistance more just that it's new and not everybody had the training in the way that you did, and sort of the other things that you mentioned?
Yeah. I think a few things. So a couple years ago, several years ago now, before the data was as robust as it is now, I think there was some, legitimate concern many years ago that, is this worth it? Did it work? Because you don't want to put patients through anything, even if the risks are very small, if you're not going to have a potential for a benefit. And now we have very clear data that shows, yes, this improves outcomes, and we have that concrete data. So that's kind of gone. The other thing is, the only thing I really modified from residency, where I learned how to do mastectomies initially to kind of fine-tune my technique in fellowship, was how I reflected that breast off the body towards the end, because I take it off kind of everywhere here, and then this last part is the last part I take, which is where the nerves lie. So I'm able to get the exposure I need. Doing it that way, I'm able to get the nerves pretty quickly. So, really it adds, if I'm struggling with a hard one, maybe 15 minutes total if it's really difficult. It really doesn't add that much to the time. Definitely the patients won't feel a difference, but I think that, those few minutes of my time for potential lifetime spared of pain, or potentially preserving sensation, or the potential to get some of that sensation back, the dividends are, through the roof. Yeah. So it's something that, does it take a little bit more time? Yes. Is it adding an hour So that's the other thing about it is, like Dr. Bank was saying, we aren't the one team in the country that can do it, you know what I mean? There are many great teams that, you know, we've met that I know across the country who are able to do this. And the big thing too is when we teach this, these are techniques that the surgeons generally have in their wheelhouse, and they just need to learn how to apply it, kind of get some practical experience. So that's another thing that's very exciting about it as well, is that you're not having to teach an entirely new, difficult procedure that takes, you know, months and 1,000 cases to get right. This is, you know, something that you're applying skills you already have or should have as a breast surgeon or a plastic surgeon, and then just applying it to a different situation and kind of looking at it a little bit differently. So that's the other thing that's very exciting, that every time we do one of these conferences, there's, you know, a dozen or more teams out there that can take this to all corners of, you know, the country and offer this to patients where, you know, they didn't have it before.
No, that all makes a lot of sense. We have a question in the chat about whether insurance companies are cover this, especially now that you're saying that there's more data around it. Could you talk about whether the nerve-sparing procedures are covered, and also a little bit of the difference between like this like idea of handling nerves with care and resensation, you know, breast neurotization procedures, like, you know, where one ends and the other begins, and how that works with insurance as well.
So the big thing with the insurance is paying for the nerve graft itself, because that is a product and that has to be approved. It has been a little bit difficult with some insurances. We just had a big carrier, I can't remember which one, which just kind of reviewed everything again and realized that this is something that benefits a patient, and now they're just covering it. So it's getting easier and easier as time goes on, as that data becomes more and more kind of apparent. It's going to be hard for them to have to ignore it. And, you know, as poorly as we often treat women in this country, there's one thing that we kind of have been able to do with some level of quality, is to try to advocate for, you know, breast reconstruction. That has to be paid for. And I think this is going to be wrapped into that eventually, where hopefully this is something that, you know, we're all just going to say, you know, this has to be covered. We aren't there yet, but I think we're getting there. But yeah, there's, you know, that is one of the issues, and so we try to do anything we can to try to get that. Now, as far as the way I do it, even if, let's say, we tried, you know, beg the insurance, you know, review, they said no, I can still preserve nerves. I can, instead of just blazing through that last little bit and cutting through all those nerves, I am able to split some of those off safely and get those against the skin. So there is some that we're always able to save. So that's the exciting part. Just kind of knowing that and changing your technique, you'll be able to save some of it. And that's what I always break it down into two kind of aspects. You have the nerve preservation and then the resensation. So the nerve preservation is when you wake up after your surgery. If I was able to preserve some nerves, you're going to feel some sensation that's usually more peripherally. And what you're able to get back is the resensation. What your body is either able to, you know, grow that nerve back through that nerve graft that the plastic surgeon put in, or just over time your body getting that back. So it's kind of a twofold. What you wake up with, you know, right after surgery is what we're able to keep, and what you get back can take up to a year, sometimes two. And so it's kind of that twofold. One is immediate. You can see how, you know, if I was a ball in a china shop, and then the other part is, you know, what your body's able to do with that afterwards.
And that definitely varies person to person. As a little PSA, breastreconstruction.org has another Instagram live that was dedicated to resensation, that is available for view on our Instagram and on the website. So you can check that out if you want to know a little bit more about the finer points and data. Pivoting back to the team concept for a second, I have another question that just has to do with selecting doctors that work together. What happens if I go and I meet a breast surgeon who I really like and a plastic surgeon who I really like, and they've never worked together before? Is that typically a problem?
You
How to coordinate?
you can make that work. There's a couple. I've had a couple situations where that's the case, where I didn't know them as well, but it all is just a communication. Because even though I might not have a years-long relationship with them, we know each other's languages, and so we can discuss that before we ever make the first cut, and that's important to do as well. As far as most cancer patients that come to me, they come to the breast surgeon first, and then I send them on to the plastic surgeon who I'll work with. And so that's usually the case. I do have several patients who follow me as part of a high-risk clinic, so I have that relationship, and then we'll forward them as well. I occasionally get the genetic mutations myself, but I think just the way some of the internet content is laid out, as well as just kind of how people think of mastectomy reconstruction. Kind of the first thought for most people who haven't gone through it is the plastic surgeon. Possibly not realizing just because the world it's the two that do it together. So a lot of those come from the plastic side and then get referred to me. But either way, it's usually they come to one or the other, and then the patient gets kind of in contact with the other provider.
Okay, that makes sense. I think now we're heading toward 8 o'clock, that we're going to wrap things up. Is there anything that either of you would like to talk about or mention that we haven't covered so far?
I think the only thing I would say is that, back to the attitude of how you go into this, and I've told people this when I meet them online, but I tried to conceptualize this as like an ultra marathon or something I was going to do. So I tried to, and I always exercise a lot, but I really got in extra good shape, ate extra protein, and really tried to think about the whole thing as though I was doing something that was big and hard, that people climb mountains. And I think that it gave me a lot more feeling of agency to conceptualize it like that, as opposed to something that was happening to me. And again, because I didn't have cancer, that was a lot easier to do, but I do think it's a helpful way to think about as you go into surgery. I know there was somebody online who was saying she was feeling anxious about doing it in January. And I think that, it's like 2 weeks where you're really out of it. I got the flu from my kid week 3, so that made it a little bit worse. But by week 3, you're kind of like able, if you're not sick with the flu, able to do basic things like cook meals, walk around your neighborhood, take the subway. But you should really consider, and that's for DIEP flap. I think for implants, it's probably a little bit faster.
Yeah, and I think I like to stay positive with my patients. If I see any level of trepidation as I'm meeting them prior to surgery, just try to remind them, this is going to be a hard day, but it's going to be a good day. And for a lot of people, the worst part of it is the anticipation before, because the unknown can be very scary.
Absolutely. It's a mental game. It really is. How do you manage your anxiety?
Yeah. So yeah, I think just having that attitude, knowing that, and then I think, Katherine, you're exactly right. A lot of things are done to you. You know what I mean? For our cancer patients, if they need chemotherapy, they go and they sit and they get drugs pumped in them. If they go to radiation, if they have to get that, if they get surgery, things can be very passive. So I think having something that you can focus on and say, this is what I'm doing for my health, for my recovery, I think is very important, because it can be very, and there are certain parts where you just have to be the patient. But, our goal with all of our patients and for you was to get you back to being Katherine and not the patient. You know what I mean? And so, yeah.
Okay, well, I think
Thank you.
that's a really lovely note, I think, to end on. And I'm going to get this out while my audio is still okay for 2 seconds. Who knows what's going to happen next? Anyway, thank you so much for your time, Katherine and Dr. Larson, and for bearing with us with these mystery technical problems. For anybody who joined us or joined for the end, this will be available both on our Instagram and on our website, breathreconstruction.org. Follow us if you don't already. And please sign up for a newsletter if you haven't signed up for that. It's a good way to just stay current on what's going on, new website sections, Instagram lives, etc., etc. Thank you so much for your time and have a wonderful night.
Thank you.